I am Ms. Sharma, host for this session. I request Dr. Shraddha Patkar ma'am to start this session. Thank you, and over to you, ma'am.
Good morning, and thank you for this opportunity. So what I would be discussing is mainly the applied anatomy of liver and how it is relevant for surgeons to know it, and how it helps us plan our liver resection. Is my slide visible? Is it okay to continue?
Yes, ma'am. Yes, ma'am. Please continue, ma'am.
Okay, so one of the things for oncological liver resections is that precise knowledge of the surgical anatomy is imperative. This helps us to plan our liver resections, to troubleshoot during liver resection, and also tackle any complications which may arise during and post surgery. So, liver is a unique organ. We all know that it has its regenerative capacity, and this very famous picture from the first page of Blumgart actually very clearly illustrates what the basis of all liver surgery is. This is basically a photograph of Prometheus, who was punished by his father for giving fire to the humans, and an eagle used to come and devour his liver every day. When he came the next day, it was found that the liver had grown. So this forms the basis of all oncological liver resection. Also, the liver is a unique organ. We know that it has dual blood supply with a very high vascularity, mainly by the portal vein and also by hepatic artery. There are three efferent veins which drain and form the major support of the liver. And the segmental anatomy is what forms the basis of our liver resection. And it is unique in that it has its own outflow and inflow. There are some peritoneal attachments and ligaments which one should be aware of. This is a very simple picture which is taken from an anatomy textbook, where the bare areas of liver are illustrated, and also the ligaments, that is the right and the left triangular, and the coronary ligament in the most superior aspect. These are important because we have to know that once we mobilize the liver, what needs to be cut when we need to get access to these areas. And also importantly, in the post-operative period, there are some areas where they are notorious to form collections in the post-operative period, which may need to be drained. Gleason sheath is something which the Japanese are very famous for propagating the principles of a Gleasonian resection based on this. It is basically just a facial condensation which occurs at the hilar plate, and it includes all the three elements, that is the hepatic artery, portal vein, and the bile duct. So once we need to do a Gleasonian approach, what we need to do is take this hilar plate down and amass encircle these three structures. Sometimes this may be tricky because there are variations, and this may not be always an easy thing to do. We'll come to that a little later, and how we can troubleshoot this too. IVC is something which is, we can say, the Achilles heels of all liver resection. What troubles most during a transection is notorious bleeding from the cava. And there are certain areas which are infamous for troubling the surgeon. There is this paracaval condensation just to the right of IVC before the right hepatic vein insert. That is called the hepatocaval or the Blumgart or the Makuchi's ligament, variously known. Suffice to say that it is sometimes just a thin structure you can easily tackle with an energy device. Sometimes it has a blood vessels which, if you're not aware of, I'll just cut it. It can lead to bleeding because that's a direct opening in the IVC. And when you have to rotate the right or the left liver, when you cut the ligaments, there is this adrenal vein which is in close approximation, and it has a vein which drains into the cava and also causes some troublesome bleeding, especially if there are large tumors which have multiple blood vessels supplying them. Also, the short hepatic veins are small tributaries just anterior to the IVC, which drain directly from the liver into the cava. Again, once you identify and ligate them, this approach is quite safely done. But if not, again, small openings directly into the cava can lead to notorious bleeding. So as I said, the hepatic veins are the main three supports of the liver. The liver hangs from these veins, and what you see is there is a facial condensation which is there. So usually the hepatic veins are found a little superior to what you expect. Uh, Professor Belgetti and his team was one of the pioneers in describing what is called as the hanging maneuver. They proposed that there is no major vessel occurs, which is encountered on the anterior surface of the cava, in between the cava and the liver. So actually you can pass a tape or an instrument blindly on the anterior surface and come out in between the three hepatic veins, hang the liver by these tapes, and then proceed with your transection. What it does is allows you to give a straight plane of transection without wavering, and also protects the cava at all time. It's not always possible to do this, but so those who are early in their training and learning of liver resection, this is a very elegant maneuver because it is helping you to protect the cava at all times and give you a fastest plane of transection. Nowhere is the segmental anatomy more important than a caudate. It seems to be an innocuous structure just straddling the porta and the cava, but the importance is that it receives independent supply which may be variable. There is independent drainage into the cava, and there are also small ducts from the caudate which directly drain into the hepatic confluence. So the location is what makes it important, and various people have attempted to divide the caudate lobe into a paracaval portion, a Spigelian lobe. I mean, this is. It is good to know, but what you need to be aware of is the drainage, and that troublesome bile leak can occur in the postoperative period if the caudate ducts are not secured during surgery. So we know that Couinard was the person who described segmental anatomy, and he used the basis of what we call as sections to divide the liver into 8 portions who had their independent inflow and outflow. These were divided mainly based on hepatic veins. So as you can see here, this is the cava, and these are the this is the cava, and these are the hepatic veins which divide the liver. This is the right hepatic vein, this is the middle, and this is the left. So whatever is in between segments 4 to 3 is the left. In between 5, 8 and 4 is the middle, and the right divides the right lobe into 5, 8, which are the anterior segments, and 6, 7, which are the posterior ones. This is the portal vein which is depicted, and the portal vein is what is it goes in the horizontal plane, and this helps us to identify these segments on CT scan. Cantley's line is what we follow for transection. It is a straight line which is drawn from the gallbladder fossa to the IVC. It's the same for a right or left hepatic vein, left hepatectomy, what you want to do depending on the location of the tumor. And how do you understand this segmental anatomy on radiology? And this is a cadaveric picture of a liver being dissected, and you can see that if you follow the falciform and dissect these structures, you can very well identify these segments and the hepatic veins very clearly. Just a picture and a diagrammatic representation. The same segments and sectors we need to identify on CT scan. So any liver surgeon has to be well versed with identifying segments and sectors on radiology. And this is just a simple map. You have to follow the hands of the clock and first go to the cloaca, find the hepatic vein. This is the left, this is the middle, this is the right, and you will get these superior ones. Once you come little lower, once the portal vein appears, these are the lower segments. So if you start from top, it is 2, 3, 4B, 5, 6, 7, 8, and 4A and 3. You just have to follow a clockwise pattern and you will be identifying them. Start reading CT scans on your own. Look at the hepatic veins first. This will guide you, and then come down and identify the segments. Once you have come down to the lower section and you can see the kidney, this is almost invariably segment 6. So in 2000, the Brisbane classification was introduced in order to simplify the terminology for liver resection. Whether it's actually simplified or more complicated is a matter of contention. But what they aim to say is that people used to say right hepatectomy, right extended hepatectomies. So the best thing would be to identify the type of resection based on the segment. So here you can see the shaded portion is what we do in a conventional right. This is what is called as a conventional left. And once you want to do a segmental resection, this is 5-8, this is anterior section, that is the right anterior section. 6-7 is the posterior section. Segment 4 is the left medial section, and 2-3 are the left lateral sections. So once you also add caudate to this, it has to be mentioned separately. This is especially true for cholangiocarcinoma, where you need to remove the caudate as a part of a complete resection. And once you extend it to the other side and remove an additional portion, this is a right trisectionectomy or an extended right hepatectomy as we commonly call. And this is a left trisectionectomy or a left extended hepatectomy. So this is a simpler system. You just write the segments which are removed plus or minus the caudate. The Japanese have developed more complicated systems on whether you are doing anything to the vein, whether there is vascular involvement. But for a simple classification to begin with, this is what we follow usually. So by this definition, as I said, right hepatectomy is removal of segment 5 to 8. A right extended is addition of segment 4. Left hepatectomy is 2, 3, 4. Addition of 5 and 8 makes it extended. And we also have something called as a meso or a median hepatectomy or a central hepatectomy, in which you preserve the right and the left, remove the middle and remove the central segments, that is segment 4, 5 and 8. This helps us to enables us to save a lot of parenchyma while removing that complete tumor oncologically. So variations in anatomy are a rule rather than exception. So we must be aware. This is more so in a transplant setting, but identifying them during surgery is also important, and I'll show you why. Arterial anatomy, as you can see, this is the classification of variant arterial anatomy for the hepatic artery. And if you notice, the frequency of the most common type of branching is still only 55%. So all these are still significantly encountered, and so you have to be aware, identify them preferably on a CT scan, and during surgery, this helps us to give a roadmap. These are the implications for surgery, as I said, mainly for transplant, but any aberrant or a replaced hepatic artery must be identified during surgery. Otherwise, it can be troublesome post-operatively also. So it will decrease your morbidity in cases of laparoscopic surgery. It will decrease your chances of conversion. And if you have identified preoperatively and safeguarded them, then you may not need to do a troublesome re-exploration in these patients post-operatively. So this is for resections. If you see that if you have a replaced left hepatic from the left gastric artery, you need to identify them, especially for a left lobe. As a rule of thumb, what we do is for an HCC, once we have we stick to the right of the porta and take all these structures which are to the right of the bile duct. That way you will make sure that if at all there is a variant anatomy, you are not going to the left or near the hilum and avoid disturbing it. Similarly, for a left hepatectomy, take left of the portal vein, don't go too much in the right, and avoid injuring some anomalous structure which might be there. Similarly, venous variant, again, very important for transplant because they may need to modify the surgical technique and it increases the surgical complexity. Suppose that there is an accessory right hepatic vein which is more than 3 centimeters from the confluence. All this basically adds to your surgical complexities, and this needs careful planning in the preoperative period rather than on table, because you don't have time in transplant to sit and think at that point of time. In liver resection, portal vein variations are more relevant. Usually the main portal vein divides into the right and left. Trifurcation is another scenario which is commonly encountered. And a common right anterior portal vein and a left portal vein trunk is also the third most common, or a type 3 variation which we see. So classical anatomy is called type 1, trifurcation is type 2, and the other two are rarer and are not as significant as the first three. So this is just a line diagram which represents what I just said. This portal vein variations are the simplest to identify on a CT scan, and this actually helps us during surgery to plan and our liver resection. Something which can be identified preoperatively, that if you have a patient in which you are planning liver augmentation and has a portal vein trifurcation, you must need to identify and embolize these veins separately to get an adequate volume augmentation. If only one vein is embolized, then you may end up with a suboptimal volume. Again, in liver resections, if you have a type 3 pattern and you have ligated only the anterior branch, the posterior is left behind, you may it may not completely get devascularized, and this may lead to troublesome bleeding during surgery. Complexity of transplant obviously increases because it's difficult to clamp. If you have type 3 portal vein, you will require 2 portal vein anastomosis. This increases the time and the chance of postoperative portal vein thrombus. This is just again a simple explanation of how we need to modify our technique and prevent ischemia in the postoperative period, especially for transplant patients. Bile duct variations are the most common. Remember that if you have a variant arterial or a portal vein anatomy identified preoperatively, it is almost 100% that you will have a bile duct variation. You may have a bile duct variation irrespective of whether you have an arterial or portal vein variation, but there are different classifications for right and left. So this is the Yuan classification, which is mostly used for right, and there is another for the left. So if you have a right, the type 1 is a right posterior draining into anterior sectoral and then forming the right duct. Type A2 is, I will just come to that, this is better shown here. So you can see that the right posterior is joining the anterior over here, and this is forming the right duct, and this is the left hepatic duct. This, what is mentioned as CD over here, is the cystic duct. These are cholangiogram images. So if you have a MRCP preoperatively, you can identify them very clearly. This is a trifurcation. So as you can see, this is the superior right posterior sectoral, which is in just draining at the confluence. So if you are dissecting the hilar plate, you can injure this. So we have to be very careful while dissecting at the hilum. Try to avoid energy devices. Do some sharp dissection with scissors, and you will be okay. So type 3 and 4 are, it gets more complex. You can see that the posterior sectoral from segment 7 is draining into the left here. And these are all actually 6 and 7 are separate, and the 6 is joining below through the CHD. So suppose you are doing a transection at this level, you will encounter almost 3 openings which have to be identified and sutured individually. Just another variation of type 3. This is the anterior sector 5 duct which is draining into the left, and the 6, 7, 8 are forming a common trunk. You can similarly 5, 6 forming one trunk, 7, 8 forming one trunk. This is entering at the confluence, this is entering little lower. So the idea about showing all these variation is not theoretical. You may or may not know. The idea is to identify them so that during surgery you are well in control of how to manage leaks which are present. So the thing about bile leak is they are best prevented. With advents in intervention radiology and endoscopy, you can get away with managing them with minor post-operative intervention. But if there is a major issue, especially at the hilum, you will be left with no choice but to go in. And a patient who's operated and has a lot of inflammation lurking there, this can be a nightmare. These are the variations on the left side. This the segment 2, 3 duct 2, 3, 4 are separate, and then the posterior sectoral is inserting into the left. This is a type 2 variation. You can see 2 is joining below, 3, 4 are forming one trunk, and the posterior is separately draining. So these are all minor things, but again, awareness is important so that you don't encounter troublesome bile leak in the post-operative period. So how these variations matter? As I said, right hepatic, right posterior draining into the LHD. In a left lobe resection, it will make a difference. In right, actually, it doesn't make because you will transect it. Similarly, a left duct draining into the right hepatic duct. In a right lobe resection, it matters. And obviously, if there is a trifurcation in both sides, in both resections, you will need to be careful. So this summarizes the anatomy of liver and how it helps us in planning a surgical resection. But liver resection is not just about anatomy. It is what may be technically resectable does not always mean that the patient is going to have a good outcome, because there are two factors when a liver resection is planned. One is the oncological clearance, and one is the underlying liver status. So what makes your outcomes optimum is the decision of when and what to operate. So there is something called as a concept of hepatic reserve. Once you remove a part of the liver, whatever is left behind has to meet the demand of regeneration and healing, plus the functional obligations of the liver, which we know are the metabolic functions, protein synthesis, detoxifying. So if any of them is impaired, you will have something called as post-hepatectomy liver failure, which is the most common cause of mortality after liver resection. So as I said, to do a safe liver surgery, what you need to do is achieve a balance of resection with adequate margin and to balance the underlying hepatic functional impairment. A lot of our patients, we are still seeing a lot of patients who are cirrhotic due to hepatitis B and C. Hopefully this will plateau off and come down in the near future, because now vaccinations are around 20 years into the market. But then we are seeing an epidemic of what was initially called as NAFLD. Now it is called as MAFLD. With India being the diabetes capital of the world, this is something which is going to be more common. So preoperative assessment of hepatic reserve is extremely important. There are volumetric tests which enable us to get an idea about the future liver remnant. But again, it's a volumetric assessment. It will not tell you what the functional reserve is. Obviously, the child score is the gold standard. We use surrogate markers for portal hypertension. There are fibro scans. There are certain tests for functional assessment as well. We have started using the ICG since the last 4-5 years. But the variety of tests say that one single test is not enough. You may use a combination of the above to arrive at an optimal assessment of whether the patient is a candidate for a major liver resection. So how much to resect? So as a rule of thumb, in non-cirrhotics, we want a 30% future liver remnant. Some people go down to as low as 20 to 25, but that's giving a little bit of sleepless nights. 30 is something which should be considered as a ballpark figure. And there are various formulae to calculate the future liver remnant. You can do a CT volumetry, which is manual, or you have this semi-automated softwares which are available in the market to help you guide the transaction plane as well as calculate this is what is left behind, and this will give you the future liver remnant. A simple criteria to see what you can resect: if you have ICG tests at your disposal, do the ICG test. It has to be done fasting. You have to calculate the dose based on body weight. And once you get the ICG clearance, if you have an impaired ICG test, these are the cutoffs which are given for what you can do. So anything which is less than 10% is fine. You can go ahead do extended resection, and variously if your ICG is impaired, then it slowly your limit of resection goes down. Having said that, you cannot do ICG if a patient is jaundiced, because it's a photospectrometric analysis, so elevated serum bilirubin interferes with measurement of ICG. This is called the Makuchi criteria, and it's simple. Also, you need to have an exact collection time and processing without delay to have an accurate ICG clearance test. There are a lot of transection devices available for making a liver resection safe. You can use whatever you have at your disposal, and if you don't have anything of simple bipolar and a finger and a Kelly glycis also works. So I mean, all these gadgets are good. They decrease the time, but if you don't have them, it's not that you can't do a liver resection. The most commonly used is the CUSA or the Cabitron surgical aspirator. We used to have this water jet previously, where it's actually a very simple device which uses the water current to transect the liver parenchyma. And there are procoagulators, there are vessel sealing devices. You can use the ligashire, the harmonic. But again, when you use energy devices, they seal small vessels, but they also seal bile ducts. But in the post-operative period, if you have a bile duct which has been sealed during surgery, it might just open up and cause a bile leak. So what we practice is something like this, that in the superficial layers you use the ultrasonic dissection either without or with a precoagulating device, and in the deeper parenchyma you use transection devices like the CUSA or water jet, and as I said, Kelly glycis is an elegant method itself. So there are two ways of how you use the CUSA. It is the vertical for faster transection of the liver parenchyma. When you start liver transection, this is how you normally go ahead with. And once you go a little deeper into the plane, then you change your transection technique to horizontal, because this is in line with the vessels and the biliary system. So what you want to do is essentially make them stand out so that you can identify them and either ligate or clip. So these are the various techniques which I already said. That you have the classical finger fracture method. to cheliclysis, to ultrasonic devices, to the water jet, and the energy devices. Either you have the harmonic, ligashire, thunderbeat. There are in fact in RFA based techniques as well. And lastly, you can use the vascular staplers as a final step for sealing before you take out the specimen. So, what I would now allude to is how do you select your approach to liver transection? Now you've known the theory, you've known the anatomy, you have identified, you have all the gadgets, but this is also something which is important. There are various surgical techniques which are described. Each has its own advantages and disadvantages. It essentially is based on the type of liver tumor, the location, and sometimes we may need to use a combination of these depending on what kind of tumor we are dealing with. So, anterior approach is something which was described actually quite long back by a Vietnamese surgeon, but this was popularized by the Japanese surgeon called Ozawa in 1990. The idea is to begin the transection along the line of the scissura, that is the Cantley's line. The hilar elements are dissected and ligated intraparenchymally during transection, and the hepatic vein is taken at the end. What happens is with this, you don't have a vascular control, so it may increase blood loss, but it avoids rotation and displacement of the lobes and decreases the chances of injury if you have, especially if you have large tumors where you don't have access and they are stuck to the diaphragm or the cava. So the anterior approach is more suited for these kind of big tumors. You can see that the plane with diaphragm here is little doubtful. We can dissect little bit of the liver, get access. What we do is just modify a little bit, take the portal structures if you have good access to them, so that you have some kind of inflow control. Ligate of the hepatic artery and portal vein, so that this once the inflow is achieved, you don't need to be bothered about troublesome bleeding. You have a reasonable control on this. And then once you get the demarcation, do a parenchymal division. This is a water jet being used, as I said. It's a very simple technique. It helps you see that the vessel was cleared. Then maybe you ligashire or a clip. A small tip that all bile duct divisions are usually done intraparenchymally. This helps us to avoid injury to some aberrant ducts which we have not identified. And once these small hepatic veins stand out, you can just clip them and secure. Once you have gained enough access by during transection, then you can go and remove this retroperitoneal attachments. As you can see, we have not mobilized the liver at all. The cava is seen in the center, the two lobes on either side. This is the large tumor. The hepatic vein is secured with a vascular stapler. And after that, you mobilize the liver and get it off. Sometimes a part of diaphragm may be need to remove. That's a call which can be taken intraoperatively. It's always safer to remove a part of the diaphragm rather than dissecting it between the tumor and the diaphragm fibers. The hanging maneuver, I briefly alluded to before, that this is mainly based on the principle that there is a avascular plane between 3 and 9 o'clock, which makes this maneuver possible. This was described by Professor Jacques Belgetti from France. And the classical hanging maneuver was actually only a blind instrument or a tape which was passed. But I would be a little skeptical if I had the previous patient scan in front of me with a large tumor and doubtful planes with the diaphragm and cava. But having said that, if you're in beginning your liver transection, this is a very elegant approach. It will help you to not waver from the transection plane, and also protect the IVC at all times. So small intraparenchymally based lesion is good for an hanging maneuver, and an attempt should be made to hang the liver in all patients. What we do is a little bit of modified hanging where we mobilize the liver, take all the short hepatics, isolate the hepatic vein carefully rather than blindly, do it under vision. Once the hepatic vein is looped, then pass a tape. You can use any umbilical cotton tape. Sometimes people use a Riles tube as well. That's also fine. And once you have secured this, you have this tape protecting you protecting the cava at all times. And this is what we get. Actually, this is a right hepatectomy, but the tape can be rotated to come out in between any of these hepatic veins. So this is the cotton tape which is protecting the cava and giving you a guide for transection. The water jet again can be used very nicely over this without damaging or cutting the tape. As a final step, only the right hepatic vein is left. Again, you can use a vascular stapler, you can put a vascular clamp and remove the specimen. Sorry. The hepatectomy with Glisonian approach was popularized again by a Japanese surgeon called Professor Ken Takasaki, and he was of the opinion that if you detach the Glisonial pedicle from the liver parenchyma, you can selectively take these segmental branches to achieve devascularization. And the concept of Glisonian pedicle approach is mainly for doing parenchyma preservation in cirrhotic patients, where you want to just selectively take the pedicle to that segment of the liver and remove it. This helps you to give a good oncological clearance as well as limit the amount of liver that you need to remove. So Glisonian approach can be done for any kind of tumor. It can be done for right, left. It is well suited for centrally based tumors because you get good access to the porta. This was essentially a segment 4B5 lesion where once we achieved a portal control, we were able to loop both the pedicles. This is the left. The left is slightly easier to loop because the left hepatic duct has a little longer extra hepatic course. The right may not always be easy, but you can switch tapes as we have done in this and take control on the left, on the right Glisonian pedicle as well. So once you have these, you know that both the Glisonian pedicles are with you, and we have started with transection in this patient and taken the right anterior pedicle intraparenchymally. So once you do a little bit of hepatotomy, you will be able to identify the right pedicle easily. This is the anterior branch of the right portal vein. In the classical Glisonian approach, what they do is arm-mass ligature. But as I said, sometimes that can cause ductal injury. So it's better if you can identify each structure individually and then take it. So once the anterior sectoral duct is ligated, that's about the last step which is needed for removal. And these also need to be secured again with a ligature to prevent bile leak in the post-op period. So now you can see that both the pedicles are isolated, and what we ligated here was the anterior Glisonian pedicle. So similarly, as I said, Glisonian approach can be used for any kind of tumors. Again, what we do is little bit of a modification because we want to identify the anatomy clearly. Get the hilar plate down. Sometimes life is good. You can have a favorable anatomy and you can identify the division extrahepatically. If this is the case, brilliant. Otherwise, you may need to do a small hepatotomy at the ruvius sulcus to gain access to the posterior pedicle. So the right posterior hepatic artery branch is ligated. So as I said, in this case, with favorable anatomy, we could ligate the posterior branch as well. And once you do this, unless there is some aberrant supply, you will get a good demarcation. You can see here, and this helps you to mark the transection plane as well. This is very clearly seen, and once you mark the plane of transection, the hepatic veins which you encounter in the transection line, you will have to serially clip them. The right hepatic is kept with on the body side, and the segment 6 and 7 drainage is usually ligated. Sometimes it may not be able to fire the stapler during surgery. You can take the pedicle intrahepatically as well. So you can see there's a small tumor here, and you have managed to do a good resection without removing a lot of liver parenchyma. This is something which is a good approach for large hemangiomas. You can see that almost the complete right lobe, a little bit of segment 4 is being involved. And what is our approach to hemangioma is there is a pseudo capsule which surrounds the lesion or the tumor. You need to identify that pseudocapsule, and once you identify it, a little bit of blunt dissection helps to kind of enucleate the tumor. These are not malignant tumors, but sometimes you may need to take the inflow just to decrease the blood supply. And as you go transecting, you will realize that the hemangioma becomes actually very soft, and what was a huge 20 centimeter one by the end of surgery is actually a small 5 centimeter lesion which we remove. This is the capsule which we aim to identify. This is it. So once you have identified it, just stick to the edge, and you will not encounter troublesome bleeding or bile leak. In this patient, because it necessitated a right hepatectomy, we had to take the inflow and divide it to get the complete tumor out. Again, last step is always the division of the right hepatic vein and the complete tumor. So if you realize, it's not appreciated, but the lesion becomes very soft by the end of the surgery because you have taken all the vessels which were supplying it. Lastly, the minimally invasive approach has been widely propagated now, at least for peripherally placed tumors and left lateral sectionectomy. For this also, you need the crux is to have a good patient selection and careful planning. Just a few pointers about if you are starting with laparoscopic liver resection, these are the surgeries to go ahead with initially. Remove the left lateral or segment 6, which are easy to approach, and there are ways to identify how difficult a transection plane would be in laparoscopic. So there's a difficulty difficulty scoring system to select patients. But having said that, with the advent of energy devices, laparoscopic ultrasound, laparoscopic liver resection is actually quite safe, and we will soon see an expansion of these indications. Just a tip about troubleshooting before I end. It's very common in your initial learning curve to miss the plane of transection, either right or left. It's important that the surgeon as well as the first assistant gives proper traction on either side, and it's important to have a good first assistant as well. So if either of them is pulling too much, you tend to waver in your plane of transection, and what happens is you encounter bleeding, and the worst part is if you injure the bile duct of the liver that is going to be left behind, it's going to be really difficult. Intraoperative bleeding can occur at various steps. Sometimes the porta is difficult, especially if a patient has undergone transarterial embolization procedures, or if you're dealing with a hilar cholangio and there is a drainage procedure done, if you have bulky nodes at the porta. Dissection of the Makuchi or the Blumgart ligament, be aware that there will be a lurking vein somewhere over there. So it's always better to ligate off that structure rather than control the bleeding. And once you, as I said, the hepatic veins are superior to what you expect. So once you dissect those ligaments, an inadvertent cautery injury or just a small nick may happen in the right hepatic vein. If that does occur, remember that's a direct opening in the IVC. So you need to be cognizant. Just put some pressure, get adequate exposure, and try to suture it at that time itself before the rent extends into the suprahepatic IVC and into the atrium. Hilar plate dissection and injury to biliary tract I've already covered. Biliary leak in the post-operative is the most troublesome. And once you have a patient who has bile leak and goes into sepsis, it almost becomes an unsalvageable situation. Caudate lobe resection is mandatory for cholangiocarcinomas, so the caudate has to be completely mobilized off the cava. All the draining veins which into the IVC need to be taken, and the duct has to be secured carefully at the time of after the resection, just to make sure that you don't have post-operative leaks. A couple of papers, if you're interested in, these are available online about how we have standardized our liver resections and how a multidisciplinary team liver tumor clinic board has helped us in this. And we have now expanded our experience to over 1,000 patients and looked at what is called as textbook outcomes. And around 65% of our patients have achieved this. There are various predictors of textbook outcomes, and this paper is available online, free to download. The most important is for a patient who cannot achieve textbook outcome, the reason is PHLF, and this is the most common cause of mortality still in our setting. We want to get this to below 10 to achieve a zero mortality rate. So the key is you don't want up to PHLF-B we can manage. The moment a patient goes into PHLF-C and requires invasive ventilation, inotropic support, it's almost difficult. And we are not yet there to look at salvage transplant as an option in an Indian scenario. So just to summarize, accurate knowledge of anatomy and careful patient selection, I cannot overemphasize this, is absolutely essential. Whatever techniques I have described have their own disadvantages, advantages. See the scans carefully, select what is best suited, be open to combining either of these approaches. You can do that once you are aware and comfortable with both, with all rather, and you can use a combination of these to make the surgery more effective and safer. Thank you so much. Happy to take any questions if there are.
Shraddha, a fantastic talk. I thoroughly really enjoyed, and a superb talk and very beautifully analyzed. The topic exactly I discussed with you, you beautifully, seamlessly took from basic anatomy, applied anatomy, advanced anatomy, and their clinical relevance. And your publications, evidence, photos were outstandingly good. I'm really heartfelt thanks to you. I thoroughly enjoyed superb work, and I hope our students know the treasure of knowledge you shared today. It would take several years for them to assimilate and understand what you put today in just 1 hour and all your slides. Thank you very much. Fantastic work. I'm so happy. Thank you very much.
Thank you, sir. Thank you for this opportunity.
Thank you. There are some questions. Kiran Bagul is asking, what is the significance of preserving MHV during right hepatectomy?
I just want to tell the residents one thing, that the two things which help the future liver remnant to function as adequately as we think the volume on CT scan is the outflow. So remember, the hepatic vein is also going to have drainage from segment 4. Okay, so if you want to sacrifice the MHV in a right hepatectomy, always calculate the congestion volume for segment 4, because unless you are very sure on CT scan that the segment 4 is not draining into MHV and it has a separate drainage into the left, in that case you are quite okay sacrificing the MHV. Unless you need it for oncological clearance, I would say that please preserve the MHV. The better outflow you have for the future liver remnant, the better it is going to function in the post-operative period. If you cannot preserve for oncological clearance, then make sure you have a good drainage established from segment 4. You can either reconstruct it, or if you have an anatomy which is favorable, brilliant, you don't need to do anything.
Thank you. Then, Sadhwani is asking, ma'am, left lateral segment means only segment 2 or segment 2 and 3?
Segment 2 and 3 as per definition.
Okay, and Divyang is asking, in cholestasis OJ, increase serum bilirubin. What is the best recommended method for functional liver assessment? Is it technetium 99 GSA or any other option?
So when the patient is jaundice, unfortunately, whatever you do is going to interfere, because all the tests which you have are photospectrometric, the ICG clearance. You can get a volume assessment based on CT volumetry. The scintigraphy is a good test, but unfortunately, again, it's a global representation of the liver function and not necessary of the future liver remnant. So it will give you an idea about how the liver is going to behave generally, but not specifically the segments which you are going to leave behind. So that is why decision making in cholangiocarcinomas regarding function remains a challenge. What we have shifted now in our practice is, since anyway they need some kind of drainage procedure, it's maybe wiser to add a portal vein embolization in the intervening time to augment whatever liver we can get.
Raksha is asking, is caudate lobe resected in any hepatectomy, and the rationale, unless it is involved? So is it always left behind, whether it is right or left?
So the histology is what matters. In cholangiocarcinoma, it is resected even if irrespective of whether it is involved or no. The reason I said is the drainage of the caudate ducts into the hilum is unpredictable. If you have a hilar cholangio, you must remove the caudate lobe completely to get an R0 resection. And this is not just based on philosophy. The Japanese have done a study in patients who have undergone a resection for cholangiocarcinoma and seen that the caudate lobes are involved in up to 50%, more than 50% of the time. So actually, to say R0 resection for cholangiocarcinoma, you need to remove the caudate completely. In HCC, you may not do so. You can leave behind the caudate. Having said that, to get access to the inferior portion, you will need to cut through the caudate to either get your tape out or access the cava anterior surface. So you can remove what you need to get access for and leave the rest behind. So that's fine.
Okay. Then Divyang is asking, what is the difference between portal vein occlusion with or without total liver venous deprivation?
So total venous deprivation is, I'm assuming this is for liver augmentation. It gives you an additional way to augment FLR and faster way. Only portal vein embolization is seen that you do not get an adequate hypertrophy. If you add a dual vein to it, that is, you block the hepatic vein as well, then the liver augmentation is faster, and maybe you can get the patient on table faster rather than just doing a portal vein ligation or an embolization.
Okay. Rakesh is asking, is it necessary to remove gallbladder in lateral segmentectomy as well?
No, but if you need access to the porta to apply a Pringle or just do a lymph nodal clearance, especially if you are. So what I do is for colorectal liver meds, we usually dissect the porta as well, just to make sure that you have sampled the nodes and staged the patient adequately. In that case, you may remove the gallbladder. But if you have a very small peripheral lesion in the lateral sectors, you can leave the gallbladder behind. There's no issue.
Dr. Neeta is asking, you told about the plane of the portal vein and the duct horizontal. Can you please repeat that again for her benefit?
Okay, so once you start the liver transection, you will see that there are vessels which traverse horizontally. Those are usually the portal vein branches and small biliary ducts. So even if you have do a complete Pringle maneuver, you will see that the bleeding never stops, because these cross channels which exist, and in the transection plane, whatever comes horizontally are either biliary ducts or portal vein branches. On the other hand, hepatic veins are something which you will see on the surface of what you are transecting, and they are thin-walled vessels. You will see the respiratory variation is reflected because ultimately the hepatic veins drain into the cava, into the atrium. So that is just something which you how to identify the veins on the while transecting. It does not have any significance what is whether it is a named vessel or no. It is just what is horizontal on the when you transect is portal vein and biliary radicle, and what is seen on the liver surface is usually hepatic vein.
Asif Ali is asking, in right hepatectomy, is it mandatory to all the time ligate the right hepatic duct?
Yes, so unless you remove whatever is draining, the three structures, that is the right hepatic artery, portal vein and the duct, you will not get a complete inflow. And what I meant to say was by transecting the right hepatic duct intraparenchymally was just to avoid some kind of inadvertent injury to a left anomalous drainage. So all the three structures, the bile duct, hepatic artery, portal vein, at the inflow have to be taken, as well as the right hepatic vein at the cloaca, which is the outflow.
Divyang Sadwani is asking, post ALPS, one of the cause for failure is it because rapid structural growth of FLR will not coincide to the functional growth that is required. Is it true?
Yeah, so a lot of initial enthusiasm about ALPS waned off because of this reason, as well as the morbidity because of biliary leak. And it was mainly for colorectal liver met. So now ALPS, the initial enthusiasm has kind of waned off, and now people are looking at combining dual vein with portal vein ligation as a safer alternative to doing ALPS. So I have no or minimal experience you can say no experience with ALPS, but my main concern about offering ALPS to a patient is the morbidity due to bile leak rather than the liver augmentation.
Thank you. Dr. Neeta is asking, we do ligate bile ducts at the hilum and intraparenchymal, but do we need to ligate the bile ducts at the surface of the liver, or the harmonic or the, whatever vessels here we take is adequate?
Usually minor bile ducts on the surface, if you can identify them, my suggestion would be is to clip them. A small clips don't take too much of your time. But sometimes what happens is they do get cauterized in your harmonic or ligature. Minor ones on the surface usually don't cause troublesome problem if you have a distal passage which is patent. Unless there is an obstructive system, it usually won't lead to any troublesome bile leak in the post-op period. But caudate is something which I would definitely not want to ligate off. They are just variable in their anatomy. So, and how big or small they are. So it's better that you ligate off the caudate ones. The small surface one, don't bother so much. But having said that, I always do a bile leak test at the end of a hepatectomy. You can use saline, you can do a cholangiogram, you can use propofol, methylene blue, whatever whatever is available to you. So if under pressure you can see some minor leak, you can just take a small PDS suture and tackle them that time as well.
Thank you. There are multiple questions keep coming, but I always tell this, the purpose of mentor is not to spoon feed them, but to stimulate their mind, show the direction, show the vastness of the topic, where they can improve. Eventually they have to walk the path themselves with the guidance which has been shown by you and all the mentors and teacher. So they have to learn it and they come back to teacher for more clarification. Thank you very much, Shraddha. So I will end this, even though there are so many questions. This shows how important this topic. Maybe down the line, after a couple of months later, I'll invite her to speak on next other topic. We can continue that. As I always say, from the national board and NBEMS students and myself, we have nothing more to give than the best wishes and blessings to you and your family for the selfless act of sharing you're doing. Thank you very much, Shraddha, and have a nice day, and I'll let you go. Heartfelt thanks to you.
Thank you, sir. And if anybody has any questions, I'm happy to chat via personal contact mail. I'm available all time. Happy New Year, everybody. Thank you so much, sir.
Thank you. Over to you, Amit, please.
Thank you so much, sir, and thank you so much, ma'am, and thank you all attendees to being here. Thank you, sir and ma'am. Thank you.
Bye.
Bye.